Good evening. I'm Dr. William Long from the Longevity Lounge. Tonight we're going to have a discussion of chronic renal failure, and I have the privilege of having a colleague of mine, Dr. Kimberly Jones, who's a PharmD and a former professor at Wingate University. So Kim, why do we decide to do this talk? We have a whole bunch of things we could have done.
Yeah, I feel like we have made a really big impact with our patients who have chronic kidney disease. And about 15-20% of the population has CKD. And
That's right.
A lot of them don't even know it because it's asymptomatic, which means you don't feel any symptoms until, unfortunately, you're in the advanced stages.
Yeah, I think that's it. That was kind of our thought when we decided to do this. It's a fairly large number of people. It doesn't get the glory and coverage that a lot of other cancer or heart disease do, and it affects a lot of people. A lot of people end up on dialysis because of this. So if we're going to talk about chronic kidney failure, what exactly is that? If you could explain that for our audience.
Sure. Chronic kidney failure is functional and structural damage to the kidneys. An eGFR less than 60 indicates CKD, chronic kidney disease, and also a microalbumin of greater than 30. And it should be something that lasts longer than 3 months, so not like acute kidney injury.
That's right.
But yeah.
Now, when we say this, you and I obviously understand these things, but how do we actually get that eGFR? I mean, I think you come to the doctor and people tell you things, but what did we actually do to get a microalbumin, to get a GFR, glomerular filtration rate, what that stands for? How do we get that?
So we do blood tests to get the estimated GFR. That tells you how well your kidney is filtering. And then at our office, we also get a microalbumin to tell you how much protein is getting through into the urine, and how much damage.
So we get the urinalysis, we have the microalbumin. It looks at other things too. Everybody's had a urinalysis. You get checked for blood, you check them for sugar, you check them for protein. But I think when you go to see your physician, it's important they do these things. It's important you understand what these things are. So this disease is way more prevalent, I think, than people know. What are the things, explain to the audience, what are the things that cause the kidney damage? What kind of disease process? What do people need to be concerned about?
Yeah, so in the office, we tell our patients that have hypertension, around 25% of the CKD
comes in that group.
Comes in that group of around 40% have diabetes.
Yeah, that's the big one.
We also work on smoking cessation in the office, and just modifying or controlling modifiable risk factors.
Right. So I think, again, for the audience, and so many of you out there, high blood pressure is a horrible risk for this. Diabetes, horrible risk for this.
Yeah.
You get into some other weird things, these autoimmune diseases. There may be some poor people out there with lupus, polycystic kidney disease. There's other causes, but I'd say the commonest ones, as you related, is hypertension, diabetes.
Yeah.
So when we see these people, we get their blood, we get their urine. Is there any other things that we look at particularly on these people that might be
we do A1Cs on our diabetic patients, and we also always get a lipid panel on them.
Yeah, because all these things are modifiable risk, and we want to be able to go down that road if we need to, right? Yeah. So let's just say are there certain drugs that are not good for people that can be a risk to them or not?
NSAIDs are the biggest ones that come to mind, and a lot of my patients are taking over-the-counter NSAIDs, so education is really important. It's great that I do the chronic care management in the office and remote therapeutic monitoring because I can spend a lot of time with the patients, explaining this to them and providing education, monitoring their blood pressure, allowing them to do that from home.
Yeah, and I think people don't realize that arthritic drugs, they're over the counter, Advil, Motrin, all these drugs can be damaging to the
Very
kidney in
damaging.
a population that's at risk.
Yeah.
So I think your expertise really comes in pharmacology and what, or explain what you do to really run these people through. Like, okay, now we have the patient that clearly has a lower glomerular filtration rate, say their GFR is 45, and what the heck are we going to do for these people?
So the first thing that we're going to do is make sure that they're on an ACE or an ARB. That helps with kidney disease progression. It helps relieve pressure in the glomerulus, and that's step one. Step two is going to be an SGLT2 inhibitor. Our two favorites are Farxiga and
That's
Jardiance.
correct.
And then the last gun that we use a lot is Corindia, which is a non-steroidal MRA.
Right. And just to back up a little bit, so when we say ACE and ARBs, I take one of those myself. These are medicines that you use a lot for blood pressure. And probably a lot of people get started on them out of the chute. What are the common ones? Can you explain that so that the people in the audience would know, like if they hear this, what drugs would they be?
Yeah, and ACE inhibitors are anything that ends in PRIL, Pril.
The Pril.
Yes, lisinopril, ramipril.
Yeah, you got it.
Anything that ends in Pril. The ARBs are anything that ends in sartan or
Rezuvus. I take it.
telmisartan, irbesartan, losartan. Those are all ARBs.
And they're all generic drugs, and they're all
Yeah.
inexpensive, which is a really
That's the
nice.
best part.
That is the best part, because then we get to the second group that you talked about, which is the Jardiance Farxiga. Those two products are not generic, and so what is the thing? Explain what we have to do. I think people don't understand on our side what the heck's involved in getting people these medicines today.
Yeah, it's really hard. We do so much to get these patients medications. SGLT2 inhibitors, they are unfortunately brand name.
Yeah.
So we will do prior authorizations. I do that with my chronic care management patients. I apply for patient assistance programs.
Right.
Because these are great medicines and they work in a lot of other disease states.
They sure do.
CKD.
And I think, you brought up the Corindia. That's an awesome drug. It's just unbelievably expensive if you do not run the hoops that you have to get this product approved.
Yeah.
Just real quickly, so everyone knows about GLP-1s. These are these weight loss drugs. Everybody's on them. Wegovy, Ozempic, Zepbound, you name it. What's the word on those? I know they're not approved for kidney failure, but what's your thinking on that?
I'm thinking they're not approved yet.
Yeah, I think so.
They have been approved for heart failure. They help patients lose weight, which is another modifiable risk factor for CKD. And I think they're probably next in the pipeline for approval.
Great. Now having to segue that risk factor thing, let's run through the risk factors. So would you say that probably the most common thing we see is hypertension? What are we looking for? Like, for the audience, what would you think, explain, what's a good blood pressure?
Yeah, so according to the KDIGO guidelines, which are the guidelines that pertain to kidney disease, 130/80, so 130 on the top number and 80 on the bottom millimeters of mercury is what you want to shoot for.
Yeah, and I think
That's
people,
what we shoot for.
yeah, we do, and I think people accept higher numbers and they really shouldn't.
Right, I think that's right.
Yeah, again, because there's no symptoms, and so people are like, I don't want to take another pill. Hey, I'm one of those people, right?
Yeah.
And then so if we go to the next one on our diabetics, the test we do all the time is an A1C, and that's a measurement of blood sugar over a longer period of time. You're really good at using the continuous glucose monitors on people, so we get that kind of data too. But the A1C we kind of beat up. What are you thinking about that when you explain?
Well, our patients really love their CGM devices,
Yeah, they do.
and we love it too. because we even wore them
Yeah,
around the office.
it's addicting.
It is. It's really interesting. And then our diabetic patients have had great success with getting their glucose under control and within the target range over 75% of the time.
Yeah, and their A1Cs, of course, follow suit.
Yeah.
So what would you think?
Oh, for the audience?
Yeah, explain what you think the A1C would be.
So according to the ADA guidelines, they want it to be less than 7%, but we shoot for much less in the office, often definitely under 6.5% or even more. If you
and I think, last time I did a podcast, we did dimension, they're even saying 5.5, which is really tough.
Yeah.
And then we also get into lipids, again, statins, we run the gamut of those drugs.
Yeah, everyone's on a statin.
Yeah, we're shooting for levels that are probably a little tighter than would be recommended.
We're pretty aggressive, I think, in our management.
Yeah, we use either ApoB, LDL. What do you explain? What do you think we should be trying to?
So I think we usually shoot for less than 70.
Yeah, I think we do.
Or better, unless you're high risk, then less than 55.
And as a pharmacist, I think a lot of people that take statins, rosuvastatin, Lipitor, Crestor, you name, they're the branded names of these drugs. Do you think that the complaint of muscle aches, is that legit?
I think that's legit.
Yeah,
I think that is legit. And sometimes CoQ10 helps. That's a theory. It hasn't been tested. It's part of the electron transport chain. But the patients that have supplemented with that, often they can continue their statin.
I find that to be true as well. And then, for the people that can't take statins, thankfully there's other agents available today that have outcomes data as well. So.
Yeah, we've been using a lot of Nexlizol, Nexlizet,
and then
inclisiran recently, Leqvio.
Yeah, Leqvio. These injectable agents like Repatha, they're very expensive, very difficult to get approved. But in the right patient, I think they're legitimate options for these individuals.
Yeah.
So I think modifiable risk factors are huge. I think I was wondering, does any patient come to mind that would be like a good example for the audience?
Yeah, actually, a couple patients come to mind, and the first one is probably the same one you're thinking of.
It is.
That is our girl who was stage 4.
Yeah.
And I think her EGFR was around 12 or 15.
It was low.
She came
in tearful because nephrology told her she was going to have to go on dialysis, and and she wasn't going to go on dialysis because she was 83 or 4 years old.
Yeah.
And you want to explain to the audience how we approached her, what we did?
She was already on an ACE inhibitor, and we put her on Corendia for her microalbumin and also an SGLT2. I think we used Farxiga.
Yeah, Farxiga or Jardiance.
I can't remember which one, but darn if she didn't improve.
Yeah, she did well enough that she didn't need dialysis anymore.
Yeah, that was a big win.
It was. And so I guess the takeaway there is, if you have someone who will aggressively go after your illness, that you can stop these problems. I know one of your favorite patients, who remain nameless, but Mr. Joe came in, and you had a really good save with him as well.
Yes, Joe Coffey.
Yeah, that's right.
He came in, and and he was a stage 4 also, and he has regressed to a 3B, and in the middle of 3B, so he's doing fantastic.
Yeah, with the same aggressive treatment, and I think he would be a great example. He came to me, he was a former patient and came back to us because he was unhappy with his care. But he had really, really, really not good control of his hypertension, his diabetes, his lipid. I mean, go down the list of each one of those risk factors. And thankfully, we were able to really get him to go on just about everything. He went to this CGM too. It was wonderful.
And he was going to the hospital. He had already been hospitalized 3 or 4 times.
I know.
For
heart disease.
Hypoglycemia.
Yeah, and his heart disease as well.
And we've got him under control. Ever since he's come back to our practice, he has not been to the hospital one time.
I know.
And that's really rewarding seeing that.
So I guess, having gone down this, what would you say is the number one thing you would like the audience to take away from this conversation tonight?
The number one thing I'd like them to take away is control your modifiable risk factors. So that means keep your blood pressure under control, keep your glucose under control, and if you're try to know your EGFR every time you get your lab work and look at that. Make sure your doctor's checking that, and know that there are medications available now should you have CKD or have CKD progression.
Yeah, I would totally agree with that. I think the modifiable risk factors. Again, everybody exercise. You're tired of hearing that. That is true.
Big time, it is true.
Yeah, blood pressure control, A1C, diabetic control, lipid control. All those things are very important. And I think what you said is if your doctor is not doing these tests, find someone who will, because I really think we've talked about this. If people would just do these things, I think we could do away with dialysis for most of the population. There shouldn't be some people, but most of the population probably within 15 years.
Yeah, agree.
Yeah, I want to thank you for coming tonight.
Thanks for having me.
Good seeing you out of the office. And I wanted to read this little disclaimer. The content of this and all my podcasts are not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they have, and they should seek the assistance of their healthcare professionals for any such condition. These podcasts do not constitute any doctor-patient relationship. Thank you for tuning in to the Longevity Lounge. Have a great evening.